First of all, thanks everybody for coming out on a beautiful night before Memorial Day. And don't worry that there aren't a lot of people here. These things are tough to get people to come out for anyway. I like to do it anyway. It's nice to be able to present once in a while. We don't get a lot of chances to do that. We tape everything too, so whatever we talk about here goes on the internet. So there's plenty of times to see it or refer. If you had somebody that couldn't make it and they want to hear something about what we're talking about, then it's all going to be taped, videotaped, and put on our website as well. And because just to introduce before we get going here, the foot and ankle topic sometimes is a little narrow. Not everybody has foot and ankle problems. So I'm doing two talks. We're kind of combining them together. We won't be here too long anyway. But the first talk is specifically foot and ankle. The second talk gets into some more sports medicine stuff, which covers sort of the gamut, from little guys all the way through seniors. So the two talks will kind of be mixed together. And then certainly at the end, I'm here, so I'd be happy to answer any questions as we go through it. So who am I? First of all, my name is Jason Rudolph. I'm an orthopedic surgeon. I do specialize in foot and ankle surgery and trauma, although I do a lot of, like I said, sports medicine injuries as well. I've been practicing, this is an old slide, it says 12 years. I'm actually here now 14 and a half years. I am board certified in orthopedic surgery. I live locally, and I try to treat my patients as I treat friends or neighbors. I did play Division I football, so I've suffered just about every orthopedic injury there is. Still are suffering from some of those to this date, so I can act like a patient as well as a doctor a lot of times. So who is an orthopedic surgeon, first of all? It's either an MD or a DO who specializes in the treatment and maintenance of the musculoskeletal system. And by that we mean bones, muscles, joints, ligaments, tendons, basically everything from the head down, not the belly. So we take care of all those things. And I'll bring this up later on as we go through this as well. Although I have a fairly busy practice, just because surgeon is at the end of our name, that doesn't mean all we want to do is operate on everybody. And I think that's a huge part of what my talk is about non-surgical treatment of things and prevention of injuries. In a way, we're trying to put ourselves out of business, but the fact is, preventing injuries becomes as important in education as actually treating them. So what do? We diagnose, we treat, and again, you see at the very bottom of that list is surgery. So there's lots of things we try to do before just jumping to surgery. Medications, therapy, exercising, bracing, and then as a last resort, sometimes it's surgery, although some injuries, there's no choice. It becomes a surgery problem right from the beginning. And again, I mentioned prevention, which I think is a huge part of what I want to get into for all levels. What do you have to do to become an orthopedic surgeon? Just background. Obviously, you go to high school first, 4 years of college, 4 years of med school, a year of an internship, 4 years of a residency. Most of us are now doing a year of what's called a fellowship where you specialize. My fellowship was in foot and ankle and trauma surgery. And then a couple of years in practice before you can actually become board certified. So officially that's 16 years. So I tell my patients I go to 28 years of school before I actually got my first real paycheck. So to get into the myths of foot and ankle surgery, and I'm going to go through a few of these myths. I think I have 4 or 5 of them. This is a big one. High-heeled shoes cause bunions. Not the case. Bunions are inherited. The best way to see if you think you are going to get a bunion, you look at your mom, you look at your dad, look at your grandparents. It's not a direct genetic inheritance, but that's the best way to tell what you're going to look like. How can we tell this? Well, there's people who have never worn shoes. Go to some of the islands, go to some places in Africa where shoes are optional, and you still find bunions. Of course, narrow pointed shoes make the bunions symptomatic. So bunions can become painful from shoes, or they can just be painful on their own. Even if you go and part of the treatment for bunions, we might get into later, is trying a wider pair of shoes. Well, that doesn't cure it, but sometimes it can make it less symptomatic. In ancient China, they used to bind their feet, and then you can distort the shape of your foot, but we don't tend to do that today. So obviously, all the shoes that can add to the symptoms. That's an X-ray of somebody in a high-heeled shoe, and that person does not have a bunion officially by X-ray, but you can tell in the picture how a narrow shoe is just going to squish your feet together and really make anything on the outside or inside of your foot symptomatic. Myth number 2, what's worse, an ankle sprain or a broken bone? I hear this all the time. Oh, he has a break. It's better than a sprain. Well, I think that's debatable. What's worse? First of all, what is a sprain? A sprain, one of the top 5 most common injuries that we see in orthopedics, maybe one of the top 3. It's an inversion injury. Inversion means your ankle turns in. So if you imagine stepping on a rock or stepping off a curb and your ankle rolls, that's technically an inversion injury, and what you're doing is stretching out ligaments. Now, to hit just a basic anatomy lesson, what's a ligament? Ligaments are ropes. They go from bones to bones. They don't get longer or shorter. They're the same length. They can stretch a little bit, but they're not like a tendon. Tendons, think of your Achilles. It goes up and down and moves. Ligaments stay the same length. So when you roll your ankle, ligaments can stretch. And they don't really tear in half in the ankle, they more stretch out. There's some ligaments in your knee that we might even talk about later that actually do tear, but this ligament basically stretches. So when you sprain your ankle, you're really stretching those ligaments out. This is a busy slide, and you don't even have to read all those words because they don't mean much. Grade 1, 2, 3, what do you think about that? Not so bad, kind of bad, really bad. So the grade 1 sprains I don't usually see. That's the one where you're playing baseball or walking down the street, or you step on a pebble, you tweak your ankle, kind of hurts a little bit. Day or two later, you're feeling pretty good and you don't even come in. Grade 2s are the more common ones. That's the one that I'll see where you sprain your ankle. The ligament's a little bit more significantly damaged. They're often partially torn or stretched out a little bit more, and you have trouble walking on the first 3-4 days. It turns purple. Everything starts to get black and blue, and I'll see those a lot. Grade 2 sprains are a little bit more involved. Then we're going to talk bracing. We'll usually talk some physical therapy. Rarely a surgery problem. Grade 3, the bad one, this is where the ligaments are severely damaged to the point where sometimes they're so stretched out that they won't snap back to their normal length, and they stay stretched out. Now these are the folks that can end up becoming problems. We still treat everybody conservatively. No ankle sprain gets operated on day 1. But the grade 3s are the bad ones where the ligaments on the inside and sometimes the outside, the outside and sometimes the inside are really damaged and may require surgery down the road if they don't rehab or recover on their own. That's a little diagram. I have a laser pointer here. So we're looking at your ankle from the side. The fibula, that's the little bone. Tibia, that's the big bone. And these are the ankle ligaments all around the side of your ankle. So this one here, the anterior talofibular, that's the ligament that goes from the front of your fibula bone to your talus. Then you have these that come down to the side, some that go down the back, and some that actually connect the 2 bones together. Most commonly, when you turn your ankle, you stretch this one. Sometimes you can stretch this one. The dreaded high ankle sprain that you may hear about if you follow sports, that's when you start to sprain the ligaments even up higher. So, how do we treat ankle sprains? This is what I was just talking about. The acronym, and you're going to see this a lot, RICE. It's easy to remember. Rest, ice, compression, elevation. So in essence, resting it, obvious. Ice, everybody will say, well, how long do you ice for? We usually will give a number of on for 30 minutes and off for 30 minutes. What that usually equates to is how long it takes the ice bag to melt. We don't want ice on continuously because you can actually get skin damage. And if you put ice on continuously, there's some people that have reported even getting frostbite. So we don't want that to happen. So usually just ice it until the ice melts or the bag of frozen peas melts, and by then it's been about 30 minutes. Icing, compression, that's a little tougher. That's when we talk about using an ACE bandage. ACE bandages are a little tricky to put on, believe it or not. Some people wrap them too tight and actually cause more damage. So compression is not a huge importance. Elevation is key. Elevation is key whenever you have any injury. Elevating it equal or higher than your heart, that helps bring some of the swelling down. Next step is bracing, and in my office I use a lot of braces. If you ever go to the emergency room and anybody's been there and sprained their ankle, you always get an air cast, a big hot plastic sticky thing that doesn't fit in your shoe. I usually throw them out the minute you come to me. We have much better sports braces that are more formed to your ankle, and you can tighten them up and loosen them up as you recover. Therapy is key. Just about everybody who comes to see me who has an ankle sprain of importance ends up going to therapy. Because what happens is, in therapy we do a few things. You get the motion back, you get the strength back, and the last thing that people forget about is proprioception, which is balance. Because once you sprain your ankle, those little nerves in your ankle stop working. And the nerves I'm talking about are the ones that say, okay, I'm on a rock, I want this muscle to fire so I don't roll over. And that's all part of what we do in therapy, is getting the strength, the motion, and the proprioception back. I quote a number here of 85% of even the most severe, even those grade 3 sprains, do just fine with conservative management, and that's the things I mentioned above. So surgery for an ankle sprain is rarely indicated, and just about, like I said, almost never done for an acute sprain. So why are these better or worse than ankle fractures? Well, an ankle fracture is very variable. Bones do heal almost universally, particularly in the ankle. It's pretty unheard of for an ankle bone not to heal. But sometimes those fractured bones require surgery to align the fracture appropriately. So although bones do heal, sometimes they have to be operated on to be put back in the right place. So what else can play into this? Well, which bones did you break? Is it a stable fracture? And does it involve a joint? Any fractures that involve joints become more urgencies because we want joints to be perfect. Any joint in your body, your wrist joint, your knee joint, your ankle, they have to be perfectly smooth. If they're lumpy or bumpy or not lined up correctly, that's when we worry about arthritis and things not healing well. So any fracture in the ankle that involves a joint usually automatically becomes a surgery problem. So I'll get into some of these growth plate fractures later, but this is a child. So I see we have a couple of kids in the background. But this line that you see here and this line that you see here, that's not air, that's not a fracture. Those are the growth plates, and that's what distinguishes children from adults, is they're still growing, and this is where bones grow from. So this is the tibia, this whole bone, this is one big bone, that's just the growth plate. Same thing on the outside, this is the whole bone, and that's the growth plate in the fibula. That's a very common place for a kid to break an ankle. So more often than not, when a child rolls their ankle and they come to see me, they don't usually sprain their ankle because their ligaments are stronger than the bone is in this place. So this could be a fracture right through that growth plate, and you really don't see it on the X-ray. That's one of those things we diagnose by examining and kind of pushing and see where they hurt. So here's an example of somebody that had obviously a terrible fracture and ended up with a plate going 2/3 of the way up their leg. So here's an ankle fracture that was obviously quite severe and much worse than the simple little growth plate fracture. So that's what I'm saying. When you say a fracture is worse than a sprain, it's pretty hard to say depending on how the injury is. So in conclusion, the majority of the time sprains are treated conservatively and don't require surgery. The majority of fractures do heal well, but many do require surgery. So in general, how to answer this myth, I think a sprain is probably better than a fracture. All right, myth 3. I have heel pain, therefore I must have a heel spur. Okay, heel pain has many causes. The number one cause is this long word here called plantar fasciitis. Well, it's much easier to say heel spur than plantar fasciitis. So most people, and even family doctors who diagnose people with heel pain will say, oh, you have a heel spur. Well, the fact is it's not always a heel spur. It's this diagnosis here called plantar fasciitis, which we're going to get into in a minute. This is, like I said, the most common reason that people come to see us with foot pain. The key here is it's always bad in the morning. Next one, Achilles tendonitis. We already talked about that Achilles tendon. That's the thing that moves up and down in the back of your heel. The key with Achilles tendonitis, it's usually not bad in the morning, but it's actually worse with activity. Bursitis is kind of uncommon in the foot. Bursitis occur all over our body. Bursitis are little fluid-filled sacs that occur between skin and bone. So wherever your skin kind of rubs against things like tables, we all have a bursa in our elbow. You have one on the side of your hip, so your hip doesn't rub against it. There's one in your heel. So where your heel hits the ground, there's a bursa between your heel skin and the bone. So you can sometimes get bursitis on the bottom of the foot. And stress fractures, another very, very common reason people will come to see us. A stress fracture in the heel is not necessarily as common as further forward in the foot, but certainly I see them all the time. One of our OR nurses came to me about 6 weeks ago with heel pain from walking around all day long, and sure enough, she had a stress fracture of her heel. So to talk about this plantar fasciitis, this is the most common presentation. It's actually caused by small tears or inflammation of this plantar fascia. We call it a fascia because it's not really a ligament, it's not a muscle, it's more just a thickened lining on the bottom of your foot. So the bottom of your sole, but underneath your skin, is a very, very thick band of tissue, and I'll show you a picture of it in a second. This is worse in the morning, is classic. You sleep all night long, you wake up, you try to put your foot on the ground, and just have that severe pain in your heel, take a few steps, and it kind of loosens up. There's many causes of plantar fasciitis. Sometimes it's an overuse injury. Sometimes people take up a new activity. They decide to become a runner. Some people gain weight, and the majority of the time we don't even know. It just happens. It's usually treated with stretching. I'll teach you about the stretching. If the stretching isn't working, we'll go to physical therapy and have somebody else stretch your foot for you. If that isn't working, sometimes we go and make orthotics for you, but extremely rarely does this ever become a surgery problem because by and large, we can get this one better with the simple stuff. Stretching, stretching, stretching. Achilles tendonitis. Like I said, this is the pain directly in the back of your heel. So not on the bottom, now we're in the back. And any tendonitis, anything that ends with itis, that's an overuse problem. So tendonitis is an overuse problem of the Achilles tendon. Again, it can be related to an injury. Most of the time, it's overuse, and occasionally we just can't figure out what it is. Some people will actually develop a large calcification in the back of their heel, right where that tendon inserts onto the bone. And this is now where a bone spur actually comes into play. That bone spur can move up and down and dig into the back of your Achilles and actually cause some small tears of that tendon. I'll show you a good example of that in a sec as well. So insertional tendonitis, here's our treatment options here. Again, like you can tell, it's always non-operative first with these sort of things. Stretching, sometimes a brace, sometimes a cast. If we just have to stop that tendon from moving, sometimes the only way you can stop it is putting in a cast for 2 or 3 weeks. I wrote this in big, bold, black letters because I'm not here to drum up business, but I'm here to give you some real good advice. And if anybody ever recommends getting an injection in the back of your heel where your Achilles tendon inserts, run away, because this is one place where a steroid can actually do some damage. If you have an inflamed tendon in the back of your heel that's taking a lot of stress, steroids are great. I use them all the time for different places, but in this one place, if it just loosens the tissue enough, the tendon can rupture. So I've seen 3 or 4 people in my career that had a cortisone injection and 2 days later they ruptured their Achilles. And of course that's a disaster because we went from a simple problem to one that's surgery without a doubt. When we do operate on this problem, we do 2 things. You have to remove the bone spur, the cause of the problem, and then you have to kind of clean up the Achilles tendon and then stitch it back down to the bone. Okay. So again, heel pain, you can have heel pain without a spur. You can have a spur and not have heel pain. And only for certain conditions does the spur actually have to be removed. So if you have that spur on an X-ray in the bottom of your heel and you don't have any pain, it means nothing. I have plenty of people, probably more people, that have plantar fasciitis or pain in the bottom of their foot that actually don't have a heel spur. So the spur itself is just easy to say, but rarely is it really the cause. So this is an example of somebody that had plantar fasciitis. They had a lot of pain on the bottom of their heel here. This is this heel spur in the back. See that spur in the back? And if we had the lights down, you'd see that the spur actually came up a little bit higher into the tendon itself. And this back here is where the Achilles tendon inserts, and this is where that pain is for the insertional Achilles tendonitis. If you go back to the last slide. So this is the same person where I actually had to remove the bone in the back of the heel. You see it's a little bit more of an angle now. That spur that was back here is gone. And what you can't see on regular x-rays is the tendon. The only way to get to that place is to peel the tendon off, do your bony work, and then stitch the tendon back down to the bone again. Okay. All right, so last myth I wanted to talk about with foot and ankle surgery, and this is a biggie, because a lot of people will ignore their foot problem until it's excruciating because they're worried that foot surgery hurts more than any other. I don't think that's true at all. We do deal with swelling. Shoulders, they don't swell that much. Elbows, not really. Knees, the swelling goes down. But the problem with foot and ankle surgery is everything follows gravity. So swelling is certainly something we deal with more in the foot and ankle surgery than anywhere else. However, we have lots of techniques to treat postoperative pain. And these blocks, these anatomical nerve blocks, I think has been the real key to staying ahead of the curve. We kind of try to trick you. We give you a block and numb up your whole foot or your whole ankle or your whole leg before you even get into the operating room. You have the surgery, and all those triggers that are starting the pain may not realize that the surgery occurred. And then we can start your pain medicine right away, right when you wake up. And I've had more people tell me, boy, I really thought this was going to be a painful procedure, only to find out that because we do the nerve block, because we use a mixture of narcotics, which are, necessary, but nobody wants to be on narcotics long term. Mix that with anti-inflammatories, which Motrin, ibuprofen, Celebrex, there's lots of different ones we can try, has really cut down on the amount of severe foot and ankle pain that we're having. So in general, although we do deal with swelling and it takes a lot longer for the swelling to go down, and because of the swelling, sometimes there's some problems with incisions healing, generally I think we have a pretty good hold on how to treat the pain that occurs after any surgery, particularly in the foot and ankle, by using these nerve blocks and combining with the anti-inflammatories.